Good morning. In today's QRS medicine series, we are discussing hepatology. So, this is may be useful for people who are preparing for NEET PG or NSET exams. So, why alcohol is very important in hepatology is one important disease affecting liver is alcoholic liver disease. Of course, now the terms have been changed. For example, previously, like persons having dyslipidemia or metabolic syndrome who develop liver disease was called as NASH, non-alcoholic steatohepatitis or non-alcoholic fatty liver disease. Now this term is called as MASLD, metabolic associated steatotic liver disease. Right? Previously it was called as alcoholic liver disease. Now it is called as alcohol-related liver disease or alcohol-associated liver disease. Persons may have both. They may have MASLD as well as ALD. In that case, it is called as MET-ALD. Right? So these are some of the new terminologies. So when do you suspect or when do you say that a person has alcoholic liver disease? We say that when a male has consumed more than 60 grams of alcohol per day, or a female has consumed more than 40 grams of alcohol per day. This is for a long time, for usually around 10 years. Only then we can suspect alcoholic liver disease. Why? Because if they do not fall under this criteria or this cutoff, like they are only occasional alcoholics or they have consumed alcohol for a very short time, then alcoholic liver disease is less likely. We are supposed to expect other diseases, other causes of liver disease. Because since time immemorial in our UG days, we have been used to present that usually it's an alcoholic liver disease, but there are other causes also. So that's why I have put alcohol first. So there's a questionnaire for assessing alcoholism, the CAGE questionnaire. We should ask them, have they ever felt the need to cut down their alcohol drinking? Yes, have people annoyed you by criticizing their drinking? G is, have they felt guilty or bad about drinking? E is there evidence of eye opener drinking or hangover drinking? If some of this is there, we can suspect that he has some alcohol use disorder. Okay, now the term alcohol, the plain use of the term alcoholic is not advised. So we have to find out whether they have alcohol use disorder or not. If they have one among the C, A, G or E, we can tell them as having alcohol use disorder. Of course, there are some terms like alcohol withdrawal. Alcohol withdrawal is the physical symptoms when the blood alcohol level goes down. There is something called as alcohol dependence. Alcohol dependence is physiological dependence is there. Physiological dependence and psychological dependence. When do you say there is physiological dependence? When there are withdrawal symptoms, it indirectly means that they are physiologically dependent. When do you say there is psychological dependence? There is craving. Because there are separate drugs for this. Usually, in withdrawal symptoms, we give benzodiazepines because alcohols are themselves agonist of GABA A agonist. So, to help them with the withdrawal, we should give another GABA A agonist, which is benzodiazepines. So, usually drugs like chlordiazepoxide or lorazepam or diazepam, these are commonly used. There are some drugs which are used against craving. For example, bupropion, acamprosate. So this bupropion is a NDRA, norepinephrine and dopamine receptor reuptake inhibitor. Okay. So these are some other drugs which are used in alcohol. So just a short discussion about alcohol. So now we'll discuss about investigations in hepatology. Even though the liver is a very small organ or a single organ, it is very important and it's a very confusing entity. So we'll discuss some basic tests which are used. So hepatitis A is one cause of viral hepatitis. So how will you diagnose hepatitis A infection? Hepatitis A IgM or anti-HAV IgM. Hepatitis B, we have many tests. There are two antigens, HBsAg, HBeAg, and there are three antibodies: anti-HBs, anti-HBC IgM, and anti-HBC total. Total is IgM plus IgG. Okay, there are actually three antigens and three antibodies are expected, but only two antigens are very important: HBs, AG. Remember, capital H stands for hepatitis, capital B stands for B. The small s is surface, AG is antigen. So hepatitis B surface antigen, E is envelope antigen, hepatitis B antigen. These two antigens are important. Likewise, we have antibodies: anti-HBC and anti-HBC IgM, anti-HBC total. We will discuss this in detail later. And HBV DNA. These are the tests used to diagnose hepatitis B. What about hepatitis C? Anti-HCV, and we have HCV RNA. Okay, hepatitis B is a DNA virus, so we measure the hepatitis B virus DNA levels. HCV is a RNA virus, so we measure HCV RNA levels. Leave off hepatitis D. It usually comes along with hepatitis B. For hepatitis C, it is similar, anti-HCV IgM. Okay. Now, autoimmune hepatitis, there are two types of autoimmune hepatitis. One is type 1 autoimmune hepatitis and type 2 autoimmune hepatitis. Type 1 autoimmune hepatitis, we usually measure SMA, anti-smooth muscle antibody. And in type 2, we measure LKM antibody. Okay. And primary biliary cirrhosis is another autoimmune cause of hepatitis only. We measure anti-mitochondrial antibody, AMA levels here. Primary sclerosing cholangitis is a liver disease which is usually associated with Crohn's disease or ulcerative colitis. Right? Here we measure P-ANCA. And we have another antibody, ASCA, anti-Saccharomyces cerevisiae antibody. Okay. And alcohol liver disease, we already mentioned what is the criteria to say it is alcohol liver disease. More than 60 grams of alcohol in males or more than 40 grams of alcohol in females per day for around 10 years. What is drug-induced liver disease? When there is a history of drug ingestion, for example, methotrexate, history of ATT intake, or history of paracetamol, if it is there is no need of any investigation. It straight away tells that it is drug-induced liver injury. And what is non-alcoholic steatohepatitis? I just told NASH. The newest term is MASLD, metabolic associated steatotic liver disease. To say MASLD, person should fit into the criteria of metabolic syndrome. So there are 5 criteria of metabolic syndrome: elevated triglycerides, low HDL, and person should have hypertension, which means systolic BP should be more than 130 and diastolic BP should be more than 85. They should be obese. So waist circumference should be high. So it is more than 19 males or more than 18 females for Asians. Then they should have diabetes. So fasting blood sugar should be more than 100. If one of these criteria is present, plus there is evidence of fatty liver, it comes under the diagnosis of MASLD. Previously, MASLD was a diagnosis of exclusion. Now it is not a diagnosis of exclusion because it is a diagnosis of inclusion. If there is one of these findings plus there is fat deposition, it is MASLD. Alpha-1 antitrypsin disease is a peculiar disease because there is associated emphysema and there is cirrhosis. What type of emphysema? It is actually pan-acinar emphysema. All the lobules are affected here. Whereas in smoking, we have only centriacinar emphysema or centrilobular emphysema. Here, alpha-1 antitrypsin levels are reduced. So when alpha-1 antitrypsin levels are reduced, the neutrophils secrete many enzymes and trypsins, etc. They damage the lung elasticity. Wilson's disease is a copper storage defect. There is reduced serum ceruloplasmin. Ceruloplasmin is the copper transport protein. When serum ceruloplasmin is reduced, blood levels of copper increase and it gets accumulated in the liver and excess levels are excreted in copper. So if someone asks what is the investigation of choice or the common investigation to diagnose Wilson's disease is low ceruloplasmin less than 25 milligrams per deciliter, and increased urinary 24-hour copper excretion. But the gold standard is to demonstrate copper deposition in the liver by biopsy. But this is not commonly done. So the other things are the investigation of choice. And we remember the eye findings in Wilson's disease. It can cause sunflower cataract. And we have one slit lamp, or in severe cases we can get a clinical finding which is Kayser-Fleischer ring. Hemochromatosis is iron deposition in liver. So here serum ferritin will be elevated, and iron saturation. Iron saturation is iron by iron binding capacity. This ratio is called as iron saturation. So this will be high. Plus there, if genetic mutation involved here is HFE mutation. Here iron gets deposited in multiple places like in testes, so there can be infertility. Okay, and there will be bronze discoloration of skin, etc. Wilson's disease is also called as hepatolenticular degeneration. Because copper deposits in the liver. Lenticular means it is in the lens of the eye as well as the lentiform nucleus of the brain. So it causes a movement disorder called as wing beating tremor. And hepatocellular cancer. Most chronic diseases lead to cancer. So especially cirrhosis or fibrosis of the liver leads to hepatocellular cancer. The diagnostic test here is alpha fetoprotein. Usually we do a combination. We do a blood alpha fetoprotein level plus there is a special imaging called as triple phase contrast CT. Okay, triple phase contrast CT. Remember this term. So this combination together picks up hepatocellular carcinoma. So even though this slide is a busy slide, this will give a gist of all the investigations needed in hepatology, right? So even if you didn't understand much of the things, because we are going to elaborate this subsequently, at least remember one slide for all investigations in hepatology. So we'll go one by one. So before going to each disease in hepatology, we must understand how to interpret the liver function test. So there are only two important things, basics, which you must remember. For any liver disease, always tell the time. Right? So people usually say acute, subacute and chronic. Less than 3 months is acute, 3 to 6 months is subacute, and more than 6 months is chronic. So we'll go with Harrison itself. Any liver disease less than 6 months is an acute liver disease. More than 6 months is chronic liver disease. For example, a rise in liver enzymes is called as hepatitis. So if it occurs less than 6 months, it is acute hepatitis. If the same abnormality lasts for more than 6 months, it's called as chronic hepatitis. Right? So likewise, we have acute liver failure, acute and chronic liver failure, like that. So just remember this 10. The second thing is, we should understand the pattern of liver injury or pattern of LFT. To understand pattern of LFT, we will discuss what are the components of a liver function test. One, we have ALT, alanine transferase. Previously it was called SGPT. AST, aspartate transaminase. Previously it was called SGOT. Next we have ALP, alkaline phosphatase. Then we have the bilirubins. We have the total bilirubin. Total bilirubin is actually a sum of direct bilirubin and indirect bilirubin. Direct bilirubin is also called as conjugated bilirubin. Why it is direct bilirubin? It's based on the biochemical method of assessment. It was named like that. So direct bilirubin is also called conjugated bilirubin. The bilirubin which is bound to glucuronide, that is conjugated bilirubin. Indirect bilirubin is unconjugated bilirubin. So we are not discussing in detail about the bilirubin synthesis here. So just for a revision for you. Then we have albumin. Extension of albumin is actually globulins and total protein. Then we have INR. Why INR? Because liver, one of the synthetic function of liver is to produce vitamin K dependent clotting factors. When the clotting factors are problematic, the prothrombin time increases. One measure of prothrombin time, that is INR, is nothing but patient's prothrombin time divided by control prothrombin time. So this ratio is called international normalized ratio. We can extend the liver function test also. There is something called as GGTP. Why GGTP is important is, I told you about alkaline phosphatase. So if you think of alkaline phosphatase, has many different subtypes. That is, the common alkaline phosphatases or liver alkaline phosphatase is produced by biliary canaliculi. So biliary alkaline phosphatase is the one which we want to measure in LFT. But there are other types of ALP like placental alkaline phosphatase, right? The bone also produces alkaline phosphatase, bone alkaline phosphatase, right? Some tumors also produce alkaline phosphatase. But we don't want those fractions. We want only the biliary alkaline phosphatase. So to be more confident that the ALP elevation is actually a biliary ALP elevation, we use another measure called as GGTP. Because GGTP is another protein which is produced by the biliary cells. So if GGTP is elevated and ALP is elevated, it definitely indicates it's a biliary tract pathology. Okay. And definitely we can tell alpha fetoprotein AFP. Okay, AFP is also a protein which is produced by some tumors. Okay, like embryonal cell carcinoma, etc. also will produce AFP. But a combination of elevated AFP plus specific findings in triple phase contrast CT, this together too will pick up that the person has hepatocellular carcinoma. Right? So these are the liver function tests. So based on some abnormalities, we can classify LFT patterns into two. Whether it is a hepatocellular pattern of LFT or is it a cholestatic pattern of LFT. In hepatocellular pattern, what it means, the liver is getting damaged. So the liver cells have AST and ALT. So AST and ALT will increase. The function of liver is to conjugate the bilirubin. So when the liver cannot conjugate, when the liver cells are damaged, what will happen to the bilirubin? Indirect bilirubin will rise, as well as direct bilirubin also will rise. But indirect bilirubin rise will be more. Definitely direct bilirubin also will rise. Whereas in cholestatic pattern, we have predominant elevation of ALP because ALP is produced by the biliary canaliculi. When that is damaged, there is an elevated ALP. I already told you to differentiate it from a rise of bone alkaline phosphatase and placental alkaline phosphatase. It is usually combined with GGTP. It is also elevated in obstructive lung lesions or cholestatic disease. Actually, cholestasis and obstruction usually are taken together. Obstruction is usually a mechanical cause, cholestasis is a functional or a mechanical cause. And here the most important thing is there's predominant of conjugated hyperbilirubinemia or direct bilirubin is only elevated. When do you say direct bilirubin is elevated? Then the direct bilirubin is more than 15% of the total bilirubin. We call it as direct hyperbilirubinemia. So ALP, GGTP elevation with predominant direct hyperbilirubinemia is a sign of cholestatic pattern. So that is why ALT, AST, ALP and bilirubin have a role. Okay. Now, can bilirubin alone elevate? Definitely. There is a separate disease called as isolated hyperbilirubinemia. Because if there is an elevated ALT or AST or ALP plus bilirubin elevation, we classified it as a hepatocellular pattern or a cholestatic pattern. In some cases, bilirubin alone may elevate. So it can be pure elevation of indirect bilirubin or pure elevation of direct bilirubin, or it could be a mixed pattern. If there is a pure elevation of indirect bilirubin, because remember bilirubin is produced by hemoglobin degradation. So when indirect bilirubin is more, it means more hemoglobin is produced or more of the hemoglobin is released from the blood cell. So predominant elevation of indirect bilirubin occurs in hemolysis. Predominant increase in direct bilirubin, we saw it occurs in cholestatic diseases, and mixed hyperbilirubinemia is seen in liver diseases. But there are some congenital diseases where there is predominant elevation of direct bilirubin. So the examples are Dubin-Johnson syndrome and Rotar syndrome. Similarly, we have two congenital diseases where there is predominant elevation of indirect bilirubin. It's a congenital hyperbilirubinemia. Crigler-Najjar syndrome, type 1, type 2, and we have Gilbert syndrome. So if there is a pure elevation of bilirubin, we have to think of hemolysis or congenital indirect hyperbilirubinemia. If it's a direct bilirubin elevation, we should think of congenital hyperbilirubinemia. Then what is the role of albumin? Albumin is a protein which is produced by the liver. Its half-life is 21 days. So if a liver disease is chronic or if a liver disease lasts more than 21 days, definitely albumin will be low. Okay. So albumin is used to tell the chronicity as well as the severity of liver disease, because albumin is produced by liver. If the liver is severely damaged, albumin levels will be very low. Globulin, the main important globulin in the body is immunoglobulin. So if globulin is high, it indirectly means immunoglobulin is high. When immunoglobulin is very high, we have to think of autoimmune diseases. So elevated globulin is a surrogate finding in autoimmune hepatitis. So INR we discussed. It is also one of the synthetic functions of liver. So if albumin is low or INR is high, it indicates a severe disease. So this finding is very important because in some scorings we usually use INR and albumin. So GGTP we discussed, AFP also we discussed. So putting those things here, if there is a suspected liver disease, we have to classify based on the duration into acute and chronic. So we will take acute liver diseases. So acute liver diseases, remember we are discussing liver diseases here, we are not discussing isolated hyperbilirubinemia. So if there is a liver disease, I told you either ALT or AST should elevate or ALP should elevate plus bilirubin should elevate. So if there is a hepatitic pattern, that is if there is ALT is elevated, okay, if predominant hepatitic pattern, we have to look for hepatitis A, hepatitis B, hepatitis C, autoimmune hepatitis, monospot infectious mononucleosis, so EBV virus infection, ceruloplasmin, that is Wilson's, alcohol history, that disease is called alcohol hepatitis. Then you should ask for drug history, that is drug-induced liver injury. So if there is an acute hepatitis, that is liver disease less than 6 month duration with predominant of hepatic pattern of involvement, we have to rule out hepatic viruses like HIV, HBV, HCV, autoimmune hepatitis, other infections and Wilson's disease, and of course our alcohol and drugs. Suppose if it is an acute cholestatic pattern, I told you cholestasis is equivalent to obstruction. So when do you say it is cholestatic pattern? ALP is high, GGTP is high. ALT also may increase, but it's a mild elevation. We have a predominant ALP elevation. In this case, you should think of AMA. AMA is the test of primary biliary cirrhosis. We should think of primary sclerosing cholangitis also. So these are the medical conditions causing cholestatic pattern. So PBC, PSC, of course some drugs cause cholestatic pattern, but most important thing is if there is a cholestatic pattern, we should always rule out obstructive lung disease by doing a MRCP or ERCP. MRCP is magnetic retrograde cholangiopancreatography. It is an investigation used to look for the biliary tract and pancreatic system. ERCP is an endoscopic retrograde cholangiopancreatography. It's a both diagnostic and therapeutic procedure. So cholestatic pattern, surgery or PBC or PSC, right? Surgical cause or PBC or PSC. But if it is a hepatic pattern, we see the medical things. Now the same thing, if it's a chronic hepatitis, again see the pattern. If it is a hepatic pattern, a ALT, AST is elevated and both direct and indirect bilirubins rise. The same thing, there is chronic hepatitis, right? Hepatitis A and hepatitis E cause only acute hepatitis. But hepatitis B and hepatitis C causes chronic hepatitis. Then of course our Wilson's disease. So serum ceruloplasmin and 24-hour urine copper. Then I told about ferritin level, ferritin saturation. So to rule out hemochromatosis. Alpha-1 antitrypsin. So which means alpha-1 antitrypsin deficiency is one cause of chronic hepatitis. Then of course our ANA profile, SMA and LKM1 to rule out autoimmune hepatitis. Then alcohol. Still alcohol is a cause of chronic hepatitis. So hepatitis B, hepatitis C, Wilson's, hemochromatosis, alpha-1 antitrypsin deficiency, alcoholism. These are the causes of chronic hepatitis. Now again chronic cholestatic pattern where ALP is elevated, GGTP is elevated, direct bilirubin is elevated. So there is a chronic liver disease with a predominant cholestatic pattern. Still the most important cause is surgical cause. So do an ultrasound or MRCP or ERCP. And what are the medical causes? Primary biliary cholangitis or primary sclerosing cholangitis. PBC diagnosed by AMA, PSC diagnosed by PNCA or ASA, anti-Saccharomyces cerevisiae antibody. If still we can't come to a diagnosis, the next step is liver biopsy in both, right? So only to bring you to this level, I told about the investigations in each liver disease. We discussed about the different patterns of liver injury, the timing, and this is just an approach. So henceforth, if a scenario is given or you come across any scenario, always think of the time, always think of the clinical clue which we discussed, and always think about the pattern of elevation which can help you. We'll come to this again and again to make us more thorough, because the entire hepatology is based on only LFT interpretation. So again I told you, when you see a liver test, either it is an isolated elevation of bilirubin where AST, ALT, ALP is normal, only bilirubin is elevated. This is one possibility. Or there is a LFT abnormality. LFT abnormality could be a cholestatic pattern, or it could be a hepatocellular pattern, or we can have only isolated elevation of alkaline phosphatase. If there is isolated elevation of bilirubin, I told you to see whether it is direct hyperbilirubinemia or indirect hyperbilirubinemia or mixed. When do you say direct hyperbilirubinemia? When direct bilirubin or conjugated bilirubin is more than 15% of total bilirubin, it is called direct hyperbilirubinemia. It is always congenital. Diagnosis is Dubin-Johnson syndrome or Rotar syndrome. Suppose if it is mixed, that is direct hyperbilirubin is only less than 15%. So two reasons are there. Either it is hemolysis, or we have Gilbert syndrome or Crigler-Najjar syndrome. Crigler-Najjar syndrome is usually a pediatric condition, so we need not discuss it much detail here, right? So if hemolysis is ruled out, it is actually Gilbert syndrome. So this is about isolated hyperbilirubinemia. If it is a liver disease where AST, ALT or ALP is abnormal plus bilirubin is abnormal, then think about the pattern. If it is cholestatic pattern, what I told you, it is almost always a surgical condition. So first thing which you have to do is see for the drugs to look for cholestasis, see an ultrasound or do MRCP or ERCP if problematic, right? And what are the medical conditions? Suppose if there is no surgical conditions, you check for AMA to look for primary biliary cholangitis, or check for ASCA or p-ANCA levels to look for primary sclerosing cholangitis, right? So cholestatic pattern is also very simple. So if it is a hepatocellular pattern of injury where AST, ALT is elevated plus both direct and indirect bilirubin is high, again we have drugs. So combining both acute and chronic together, in acute we have hepatitis A, hepatitis B, hepatitis C, hepatitis C, drug histories, infectious mononucleosis, Wilson's, hemochromatosis, etc. So here they are given only chronic: hepatitis C, hepatitis B, hemochromatosis, so iron TIBC ferritin for hemochromatosis, ANA profile, ceruloplasmin for Wilson's disease, right? And fatty liver, obviously fatty liver is also one reason for chronic hepatitis. Suppose if it is only an isolated elevation of ALP. If it is only an elevation of ALP, always doubt whether it is the elevation of ALP is due to a liver disease or if it is a non-hepatic cause of raised ALP, because placental alkaline phosphatase can be there, bone alkaline phosphatase can be there. Even growing children can have elevated ALP because of bone growth. So in that case, you send GGTP together. If GGTP and ALP is high, definitely it is cholestatic pattern. So we'll come back to this one. If it is cholestatic pattern, do ultrasound, MRCP or ERCP. If it is the imaging is normal, then you have to check for AMA to rule out PBC and see for p-ANCA to rule out primary sclerosing cholangitis, right? So we'll come to one by one. So again it's the same thing. So what happens in hemolysis or Gilbert syndrome? There is elevated bilirubin. So what bilirubin increases? Indirect bilirubin only increases, but AST is normal, ALT is normal, ALP is normal, albumin is normal because it's not a liver disease at all. Prothrombin time is also normal because it is also not a liver disease, right? So both albumin and prothrombin time are affected in synthetic functions when the synthetic function of liver is gone. So what happens in acute hepatocellular necrosis? What happens in acute liver disease? So it could be viral, ischemic or drug-induced toxicity. Both indirect and direct bilirubins rise. ALT rises, AST rises, but ALT elevation is more than AST elevation. What happens in alkaline phosphatase? It is mild elevation or it is normal. So when do you say it is mild elevation? When the level is less than 3 times the upper limit of normal. Upper limit of ALP is usually 125 international units per liter. So less than 3 times means it is less than 400 international units per liter roughly, right? Albumin is normal because it is an acute necrosis. So albumin is normal. Only in chronic liver disease albumin will be low. Similarly, prothrombin time. PT also will be normal initially, but once the disease becomes chronic or severe, PT will elevate. Now chronic hepatocellular disorders, again the same thing. Bilirubin, both indirect and direct bilirubin will increase. AST, ALT both rise and ALP will be normal. Albumin is decreased and vitamin K is prolonged. INR is prolonged. Now, how will you differentiate different causes of acute hepatocellular diseases? In alcoholic disease, AST is more than ALT. Why the reason? Because in alcoholism, pyridoxine deficiency will occur, vitamin B6 deficiency will occur. Vitamin B6 is a cofactor for ALT, right? So ALT reduces. Even if you don't understand this mechanism, please remember in alcoholic hepatitis, AST by ALT ratio is more than 2. So again, both direct and indirect bilirubin will rise. ALP will be normal. Since alcoholic disease is chronic, albumin will be low and INR will be elevated. Now what happens in cholestasis? Right? Cholestasis, we just discussed. There are only 2 causes. One, surgical cause. Surgical cause is called as extrahepatic cholestasis. And the other 2 diseases, primary biliary cirrhosis and primary sclerosing cholangitis, are called as intrahepatic cholestasis. Here what happens, direct bilirubin is predominantly elevated. AST, ALT usually normal or it is a mild elevation, but ALP is more. ALP is more than 400 or ALP is more than 3 times the upper limit of normal. Albumin is normal. PT is normal because they are not hepatocellular disorders, right? Last we'll skip. So time and again we are discussing only 3 types of diseases: isolated bilirubin elevation, hepatocellular diseases, and cholestatic diseases, right? Only in alcoholic hepatitis, AST will be more than ALT in the hepatocellular disease. In the chronic liver disease, what happens? Albumin will be low, INR will be low, right? In hepatocellular pattern, AST will be high, ALT will be high, both fractions of bilirubin will be high. In alcoholic liver disease, AST will be more than ALT in the ratio of 2:1. When the disease becomes chronic, albumin will be low, prothrombin time will be high. In cholestasis, we have extrahepatic cholestasis and intrahepatic cholestasis. Extrahepatic cholestasis, always do imaging. Intrahepatic cholestasis could be PBC. How will you diagnose? By sending AMA. And how will you diagnose PSC? By sending for P-ANCA levels or ASCA levels. How will be the picture? Direct bilirubin will be elevated more than 15%. ALP will be high. GGTP will be high. Albumin and prothrombin time will be normal, right? So the same type of table we are repeating again and again. Never forget these things. So coming to isolated hyperbilirubinemias. So I just told you, isolated hyperbilirubinemia could be a predominant elevation of indirect bilirubin or a predominant elevation of direct bilirubin. Elevation of indirect bilirubin could be due to hemolysis. If hemolysis is ruled out, it is due to Crigler-Najjar syndrome, type 1, type 2, or it is Gilbert syndrome. Gilbert syndrome is common in adults. So here they are given the levels, okay, how to differentiate between type 1 and type 2. So why this Crigler-Najjar or Gilbert syndrome occurs? Why indirect hyperbilirubinemia occurs? Because liver is problematic. There is problem with conjugation. Okay, conjugation of bilirubin is abnormal. That's why indirect hyperbilirubin is high. So try to find out the clinical clues here. Now, what are the causes of predominant inherited direct hyperbilirubinemias? Here, conjugation is normal, but the conjugated bilirubin is not excreted into the biliary tract. Why it is not excreted in the biliary tract? The biliary transport mechanisms are abnormal. So we have Dubin-Johnson syndrome and Rotar syndrome. Of course, there are some other additional diseases like PFIC, BRIC, etc. At least remember Dubin-Johnson syndrome and Rotar syndrome, right? I'm not going through the entire clinical scenario because my aim is only to make you understand how to come to a diagnosis of isolated hyperbilirubinemia. Okay. So now having finished one big portion of LFT interpretation, we'll come to acute hepatocellular disorders. So I told you the important acute hepatocellular disorders are viral hepatitis. We have hepatitis A, hepatitis B, hepatitis C, hepatitis E. Hepatitis D usually occurs along with hepatitis D. The thing is, hepatitis A and hepatitis C both cause only acute hepatitis. Hepatitis B and hepatitis D causes acute hepatitis. They may progress to chronic hepatitis. When do you say it is chronic hepatitis? When LFT abnormality lasts more than 6 months. Plus, anything which is chronic can also lead to hepatocellular cancer. Okay. So, we'll see with hepatitis A. So, when hepatitis A is there, what happens initially? The antigen rises. When antigen starts falling down, at the same time, antibody starts to rise. Antibody usually is of two: IgM antibody, IgG antibody. IgM is the acute antibody. It's the first antibody which comes. Once IgM levels of antibody comes down, the IgG level starts rising, and IgG usually lasts for a longer time. So IgM is the acute antibody which comes initially, lasts for a shorter time. IgG comes later, but it's the chronic antibody. I put this image because it is easy to understand hepatitis A, because when hepatitis A is there, what test we send? HAV IgM. It starts to rise a little bit later, or immediately after the infection this starts to rise. So when this is diagnosed, we can diagnose hepatitis A infection. Hepatitis A usually comes with diarrhea or an acute hepatitic illness. But you should understand this IgM, IgG and antigen concept for another important disease, which is hepatitis B. Okay, because hepatitis B has both acute and chronic patterns. So I was telling you, we have 3 important antigens for hepatitis B. One is hepatitis B surface antigen, hepatitis HBsAg, hepatitis B envelope antigen, HBeAg, and we have hepatitis B core antigen, HBcAg. Likewise, we are supposed to have 3 antibodies, right? Anti-HBs, anti-HBe, and anti-HBc. So these are the antibodies which we are supposed to see. But practically, HBc antigen has no use, and anti-HBe has no use. So we are left with only 2 antigens and 2 antibodies. So what are the antigens? The antigen is HBsAg. The next antigen is HBeAg. Then we have 2 antibodies, anti-HBs, and we have anti-HBc. Now always remember, we have 2 things, right? IgM and IgG. For anti-HBs, we need not bother about IgM or IgG. So each of these antibodies has a particular interpretation. What does HBsAg indicate? If the hepatitis B surface antigen is present, it means definitely an infection is present. So he was exposed to the hepatitis B virus somewhere in his lifetime, be it acute, be it chronic. What does HBeAg indicate? Whenever E is positive, it always indicates replication. So HBeAg positivity always indicates replication. When replication happens, what will be high? Hepatitis B is a DNA virus, so when replication occurs, HBV DNA levels will be high. So HBeAg as well as HBV DNA levels go together. Now what is anti-HBs? When antigen is there, definitely antibody will be produced. So anti-HBs also indicates infection. Can antibody be present without an antigen? Yes, in case of vaccination. Because vaccination, we introduce only few subunit of the hepatitis B vaccine is actually a subunit vaccine. So even though the HBsAg is not detected, anti-HBs will be produced because of the particular subunit which is there in the vaccine. Now here comes anti-HBc. What does IgM indicate? It's an acute infection, right? Antibodies produced, it's an acute infection. When IgG is there, it indicates a chronic infection. Remember, we discussed the same concept in HAV, right? Antigen comes first. When antigen comes down, IgM comes. When IgM comes down, IgG comes. The same concept is here, but only thing is we are having 2 antigens extra. One is HBeAg is extra and anti-HBs is extra. Why anti-HBs is important? Because vaccination is a condition where anti-HBs is present without HBsAg positivity. HBeAg is important. Why? Because it indicates replication. Anti-HBc is important. Why? Because if only IgM is elevated, it indicates acute infection. If the total is elevated, that is IgM is low, but the total immunoglobulin is high or IgG is high, it indicates chronic infection, right? So that is what is discussed here. So can you see, initially the hepatitis B surface antigen comes up. So there is active infection. So when active infection is there, hepatitis B, E antigen is also high. ALT is high, patient is symptomatic, patient is jaundiced. So then what happens? The HbSAg comes down, so anti-HbS comes. Before anti-HbS, anti-HbC IgM comes. That is why this is important. So in acute hepatitis B, when HbSAg levels comes down, the IgM anti-HbC comes up. When its level starts to fall, the IgG anti-HbC comes up. Right? So this is about acute hepatitis B. In chronic hepatitis, what happens? HBV is chronic because initially there is a replication. Sometimes they go into rest phase, or that is called as immunotolerant phase. That is, they have the virus in the body, but it is not proliferating. It is not causing any problem in the body. So how will you diagnose that there is a chronic infection? HbSAg is positive, yes, because the virus is still in the body. In acute hepatitis B, the HbSAg levels comes down. But in chronic hepatitis B, the virus is still there, so the HbSAg levels is still high. But how will you differentiate? Had it been an acute hepatitis, the IgM levels would have been positive. But since it is chronic, the IgM anti-HbC levels will come down. But the total antibody levels will be high, or that means the anti-HbC IgG levels will be high. Right? So HbSAg is positive because the virus is still present. IgM anti-HbC levels are low because it is a chronic infection. Anti-HbC IgG levels are high because it is chronic. Now what about this HbEAg levels? I told you whenever there is active replication, HbEAg will be high. So in the phases of chronic hepatitis, there is something called immunotolerant phase, there is something called immunoactive phase. So there are some times when the virus gets activated. So when the virus gets activated, HbEAg will be high. So their ALT, AST levels will be high. Their HBV DNA levels will be high. But in some times, their HbEAg levels will be negative. HBV DNA levels will be negative, which means the infection is not active. Right? So we can have multiple patterns. In acute hepatitis B, HbSAg is positive. Anti-HbC IgM is positive. And HbEAg is positive because there is active replication. Right? In chronic hepatitis B, I told you there are two possibilities. Either the infection is active or it is inactive. So definitely hepatitis B SAG is positive. Anti-HbC IgM is negative, but anti-HbC IgG is positive. Right? Now HbEAg has two possibilities. If HbEAg is negative, it indicates it is chronic inactive hepatitis B. Right? If the same scenario, that is if HbSAg is positive, anti-HbC IgG is positive, anti-HbC IgM is negative, but HbEAg is positive, it indicates the patient is having chronic active hepatitis B. Okay. If HbSAg is negative, but anti-HbS is positive, it indicates person was not infected, instead he was only vaccinated. Right? Or it may mean he had an old infection. He had an old hepatitis B infection, so the levels of HbSAg had come down, or it means he was vaccinated, right? So many scenarios usually come on this one. So that was about hepatitis B. Now coming to hepatitis C. Hepatitis C is also a virus which causes both acute hepatitis and chronic hepatitis. Usually it is not known for its acute hepatitis. Hepatitis C is known for its chronic hepatitis. Also it is known for its propensity to cause hepatocellular cancers. Also remember, it has no prophylaxis when the person has needle stick injury. Hepatitis B has prophylaxis when person gets exposed to hepatitis B by needle stick injury, but in hepatitis C there is no prophylaxis, but it is a treatable. The other hepatitises are chronic, but a completely treatable entity is hepatitis C. So this is just a structure of the hepatitis C virus. Why I portrayed here is we have three proteins, NS3, that is non-structural protein 3, NS4A, NS4B, NS5A and NS5B. There are drugs against this NS3. There are drugs against this NS5A. There are drugs against this NS5B. Any drug which ends with previr, for example, teliprevir. Okay, anything which ends with previr is anti-NS3. Any drug which ends with tasvir, like velpatasvir or daclatasvir, or anything which ends with pasvir, like ledipasvir, is anti-NS5A. 5B has B, so anything which ends with BUVAR, buvir, sofosbuvir, right? So anti-NS3 drug is teliprevir, anti-NS5A drug is velpatasvir, daclatasvir or ledipasvir, anti-NS5B is sofosbuvir. These are called as directly acting antivirals in hepatitis C. Usually a combination of these two is given, like sofosbuvir, velpatasvir. Sofosbuvir is a directly acting antiviral against the non-structural protein 5B, and velpatasvir is a directly acting antiviral acting against the non-structural protein 5A. Usually comes in combination. This is called as pan-genomic drug regimen, because hepatitis C, usually they say there are many variants, many types of genomes. But this drug you need not see the genome and treat. This is a pan-genomic regimen. Okay. And what is the investigation of choice? Anti-HCV. Okay. Please see about the capital and small letters. Don't confuse this with anti-HBC. Okay. So again, this is just a summary of the hepatitis viruses. Hepatitis A and hepatitis C cause only acute hepatitis. Usually they are foodborne and waterborne. They may have present with only acute hepatitis. Hepatitis C is known for its fulminant hepatitis, that it causes acute liver failure. Hepatitis C is known for its fulminant hepatitis and for its propensity to affect pregnant females. But by far hepatitis A is more common. So how will you diagnose hepatitis A? Anti-HIV IgM. How will you diagnose hepatitis C? Anti-HEV IgM. Now hepatitis B and hepatitis C are chronic. Okay, these are blood-borne. So needle stick injuries or blood transfusions, or hepatitis B is an STD. Okay, right. So if you want to know the drug of choice for hepatitis B, it is lamivudine, adifovir or entecavir. So if you remember, some of these drugs also will come in HIV. Okay. Nucleoside reverse transcriptase inhibitors or nucleoside analogs. So see here, this is just a summary of hepatitis B. So in acute hepatitis B, how will be the serology? Hepatitis B, S antigen will be positive because infection is there. Anti-HA, HBC IgM will be positive, anti-HBC IgG will be negative, right? What happens in chronic hepatitis B? HbSAg will be positive, anti-IgM HBC will be negative, but the total anti-HBC immunoglobulins will be high, or anti-HBC IgG will be high. When do you say it is chronic active hepatitis B? When HbEAg is positive. In this scenario, we say acute chronic active hepatitis B. That is, HbSAg is positive, anti-HBC IgG is positive, and HbEAg is positive. In this case, we call it as chronic active hepatitis. If this word active is not there, then we can say HbEAg is negative, right? So that finished about acute viral hepatitis. Now about chronic hepatitis. So remember, while discussing about chronic hepatitis, we discussed about chronic viral hepatitis. Hepatitis B and hepatitis C are the chronic viral hepatitis. Then we have Wilson's. We have hemochromatosis. Then we have autoimmune hepatitis. All these things cause the hepatocellular pattern. In cholestatic pattern, we have two diseases, primary biliary cirrhosis and primary sclerosing cholangitis. What is chronic hepatitis? The disease is lasting more than 6 months, right? So, chronic hepatitis B is the first disease. How will you diagnose? HbSAg, anti-HBC IgG levels, and to see the replication, we see HbEAg and HBV DNA. If it is high, active replication is there. If it is low, there is no replication. How will you treat? Entecavir and tenofovir. At least remember these drugs. Then chronic hepatitis C, we diagnosed it by anti-HCV and HCV RNA levels. And what is the drug of choice? And directly acting antivirals. So we have the combination sofosbuvir and velpatasvir is commonly used. Right? Sofosbuvir acts against non-structural protein 5b. Ledipasvir acts against non-structural protein 5a. Velpatasvir also acts against non-structural protein 5a. D is usually associated with hepatitis B, so we will skip it. Then autoimmune hepatitis. So we discussed it is of two types, type 1 autoimmune hepatitis, type 2 autoimmune hepatitis. Type 1 anti-LKM will be positive. In type 2, smooth muscle antibody will be positive, treated with steroids. Okay. So I think this makes some sense, right? So now we'll come to the commonest ones, the alcoholic hepatitis. So we just discussed about alcohol, when does a person is said to have alcoholic hepatitis, right? Or alcoholic liver disease. So at least remember there is a score called as Matrice discrimination factor. So when do you suspect alcoholic hepatitis? So alcoholic hepatitis is an acute or chronic hepatitis, right? So there is definitely a history of alcohol intake, a recent alcohol intake. And it is a hepatitic pattern, right? So AST, ALT will be elevated. Indirect bilirubin and direct bilirubin both will be elevated. ALP is normal. Here GGTP is elevated. This is peculiar because alcohol stimulates GGTP production. Okay, so ALP is normal, GGTP is high, it indirectly suggests alcohol, and there are some diseases, some other drugs also which cause the same pattern, right? So this is how will you suspect patient is having alcoholic hepatitis. When there is alcoholic hepatitis, we are supposed to calculate a score called as Madry's score. So the Madry score is calculated by 4.6 into change in prothrombin time. Change in prothrombin time is the patient's prothrombin time minus the control prothrombin time plus the total serum bilirubin. So the cutoff is 32. If it is less than 32, it indicates the alcoholic hepatitis is mild to moderate. Here only alcohol abstinence is enough. If the MDF is more than 32, it indicates severe alcoholic hepatitis. Here you have to give oral prednisolone. Or if oral prednisolone is contraindicated, like for example, he has severe infection or gastritis, in that case we can give oral pentoxifylline. Okay, pentoxifylline is a phosphodiesterase inhibitor. So you have to give this for 7 days. After 7 days, we have to calculate another score called as Lilly score. If the Lilly score is less than 0.45, we can continue prednisolone for 28 days. If the Lilly score is more than 4.5, we have to stop prednisolone. And finally, you should go for only liver transplant. So liver transplant is the final supportive care for most of the severe liver diseases. Right? Here they are given if there is contraindication to steroids, straight away liver transplant, but some usually give pentoxifylline also. So this is about alcoholic hepatitis, which is an acute hepatitis. So we finished the discussion about acute hepatitis and chronic hepatitis. Now see, this is how liver diseases progress. When the healthy liver, whenever there is an acute insult, there will be fat deposition in the liver. That is called as steatosis. Fat deposition in liver is called steatosis. Practically any liver disease can cause, be it alcohol, be it non-alcoholic liver disease, any drug. And this fat, when it presents for a long time, it leads to inflammation that is called as steatohepatitis. Fat plus inflammation is steatohepatitis. And still if it continues, it leads to cirrhosis. Cirrhosis is nothing but any chronic inflammation, we know it leads to fibrosis. Fibrosis of the liver, plus there should be attempts to regeneration. So regeneration of nodules plus fibrosis is called as cirrhosis. Right? So cirrhosis is like the end stage of liver disease. Right? So please remember, cirrhosis is different from acute and chronic hepatitis. Cirrhosis is like an end stage liver disease. So what happens in end stage liver disease? It's nothing but chronic liver disease, right? So we know that in chronic liver disease, albumin will be low. We know that INR will be high, right? Definitely bilirubin, AST, ALT will be abnormal. But it is usually said that AST and ALT may not be abnormal because the liver is so damaged that there is not much of AST, ALT left to elevate. Now, cirrhosis is very important because once cirrhosis occurs, some other pathologies occur. The main pathology which occurs is portal hypertension. Portal hypertension leads to ascites, hepatic encephalopathy. Right? So we'll discuss it shortly now. There is a scoring for cirrhosis that's called child score or child Turcotte-Buick score. There are 5 here. So one is serum bilirubin because it indicates problem with the liver. Serum albumin, it indicates a poor synthetic function of liver. Prothrombin time, right? So they are classified into 1, 2, 3. A scoring is given for each. Ascites and hepatic encephalopathy are features of portal hypertension which occurs as a result of cirrhosis. Again, they have classified hepatic encephalopathy. There is some grading called West Haven grading for hepatic encephalopathy, mild, moderate or severe. So based on this, we have the total score. The minimum score is 5, right? So if the score is 5 to 6, it is child A, it is mild cirrhosis. If the score is 7 to 9, it is child B, it is moderate cirrhosis. If the score is 10 to 15, it is child C or severe cirrhosis. So how will you assess this fibrosis? I think the simplest method to assess is ultrasound of the liver. but we have other better measures that is called as fibroscan. You would have heard the term fibroscan, or we have a technical term for this is called elastography. We have magnetic elastography as well as sonoelastography. Then what about these tests, APRI, FIB4? Just what you have to remember is these are some non-invasive tests to assess cirrhosis. Right? So we know that AST, ALT increases and platelet count will decrease in portal hypertension. So a calculation is made based on these factors. If FIB4 is elevated or APRI score is elevated, what it indirectly means is probability of cirrhosis is there. But how will you find out cirrhosis? By doing this fibroscan or magnetoelastography. So that was about the stages of cirrhosis and the diagnosis of cirrhosis. What are the causes of cirrhosis? Practically any liver disease, especially any chronic liver disease, will finally lead to cirrhosis, right? So what are the chronic liver diseases we discussed? Alcohol. In viral hepatitis, we have hepatitis B and hepatitis C. Autoimmune hepatitis, the MASLD, non-alcoholic fatty liver disease. Hemochromatosis, Wilson's disease, alpha-1 antitrypsin. Primary biliary cirrhosis, primary sclerosing cholangitis, right? Apart from that, we have one or two causes like cardiac cirrhosis, cystic fibrosis, etc. So what importantly happens in cirrhosis is a pathology called as portal hypertension. Portal vein is formed by splenic vein and the superior mesenteric vein. Okay, so these veins enter the liver and they divide into multiple branches, and finally they again unite to form the IVC. So why this is a portal syndrome? Because portal vein carries all the nutrients and toxins from the GIT into the liver, and the hepatic cells or the hepatic sinusoids do a detoxification. After detoxification, all the blood enters the IVC. Right? IVC branches. So IVC is the terminal center here. So this IVC empties into the heart. So that's why whenever the cardiac pressure increases or right ventricular pressure increases, IVC will distend and the pressure will be transmitted here, and the liver also will enlarge. That is called as congestive hepatitis. So in heart diseases like constrictive pericarditis, etc., liver will enlarge. That is called congestive hepatitis or congestive hepatomegaly, whatever you call it. And when this congestive hepatitis lasts for a longer time, it leads to cardiac cirrhosis. So constrictive pericarditis or right ventricular diseases leads to cardiac cirrhosis. Pathological finding here, what we get is called nutmeg liver. Okay. So when the liver is cirrhotic, what happens? The blood flow from the portal vein into the liver gets obstructed, right? So the portal vein pressure increases. So whenever the portal vein pressure is more than 12 millimeters of mercury, we call it as portal hypertension. So where all can it occur? So I told you, portal vein is formed by splenic vein and the superior mesenteric vein to the portal vein. Portal vein enters the liver and it divides into multiple branches, and it enters the sinusoids, and after the portal vein crosses the sinusoids, it becomes the IVC. This is how the pathway goes. Suppose if there is some obstruction outside the liver, example, if the portal vein is thrombosed, definitely portal vein pressure will be high, right? So portal vein thrombosis, or there is a disease called extrahepatic portal vein obstruction, EHPVO. If there is an extrahepatic portal vein obstruction, definitely portal pressure will be high. But this is called as extrahepatic portal hypertension. Now what about intrahepatic portal hypertension? When we come to intrahepatic portal hypertension, before the hepatic sinusoids, there can be some problem. For example, diseases like schistosomiasis and sarcoidosis are called as pre-sinusoidal. So even before the portal veins enter the liver sinusoids, this schistosomiasis causes obstruction. So that is called as pre-sinusoidal portal hypertension. Now, if the problem is there with the liver sinusoids itself, for example, cirrhosis, our classical cirrhosis is one cause of sinusoidal, intrahepatic sinusoidal cause of portal hypertension. So if you remember, portal hypertension, cirrhosis is not the only cause. There are many causes like extrahepatic portal vein obstruction is the prehepatic cause. Among intrahepatic, we have a pre-sinusoidal cause which is schistosomiasis. And the hepatic cause itself is cirrhosis. And after sinusoids, what happens? We have some venules which join the portal vein. So problems can occur here also. That is called as post-sinusoidal portal hypertension. And post-hepatic, that is problems in the IVC causes portal hypertension, like our classic Buchiari syndrome or veno-occlusive disease. Buchiari syndrome is obstruction of the post-hepatic IVC. Okay, so I think that clarifies portal hypertension. So this is the tabular form. So portal vein thrombosis, splenic vein thrombosis, or even splenomegaly, all these diseases will somehow cause some pressure changes in the portal vein. So this is called pre-hepatic portal venous hypertension. In liver, I told you pre-sinusoidal. Example, schistosomiasis is pre-sinusoidal. The sinusoidal causes our classic cirrhosis, or alcoholic hepatitis also can cause. Post-sinusoidal cause will be veno-occlusive disease. Post-hepatic causes Buchiari syndrome, where it is an occlusion of the post-hepatic IVC, or the cardiac causes like constrictive pericarditis, restrictive cardiomyopathy, or heart failure. These are the post-hepatic causes of portal hypertension. So what happens when the portal pressure increases? When the portal pressure increases, the blood from the portal vein will find it difficult to enter the liver and to go into the IVC, right? When the portal pressure increases, the blood in the portal vein will find it difficult to go to the IVC directly. So what it will try to do? It will try to bypass and go into the systemic circulation. So the portal circulation will try to bypass the liver and through some other channels it enters the systemic circulation, which is the IVC. So how does it bypass? By going through some collaterals. The collaterals are present in multiple places. So the most important place where the collaterals are present is esophagogastric junction. So when portal hypertension occurs, porto-systemic shunting occurs in many places. One place is OG junction. This leads to esophageal varices. Similarly, it can also occur in the rectum. That is called as rectal varices. It can also occur in the umbilical region. It leads to the caput medusae appearance. So all these are examples for porto-systemic shunts, right? So even if you don't remember the other porto-systemic shunt, you must remember that among the different causes, among the pre-hepatic, hepatic and post-hepatic causes of portal hypertension, we have cirrhosis, which is a sinusoidal cause of portal hypertension, which opens up the porto-systemic shunt leading to gastroesophageal varices. When this varices ruptures, it leads to bleeding. This is called as variceal bleeding. So one complication of cirrhosis is portal hypertension. Now I told you the portal vein carries the nutrients and toxins from the GIT to the liver, where detoxification occurs. When porto-systemic shunt occurs, what happens? That detoxification does not occur. So all the toxins, especially ammonia. How is ammonia formed? The GIT has many bacteria. The bacteria act on the food which is taken, the protein which is taken to form ammonia. That ammonia bypasses the liver through the porto-systemic shunt and enters the systemic circulation, leading to hepatic encephalopathy. So how will you treat this hepatic encephalopathy, or how will you prevent it? By giving antibiotics to kill the bacteria. That is where rifaximin plays a role. Rifaximin is a non-absorbable antibiotic which kills the bacteria. We can detoxify the ammonia somehow by giving lactulose, because lactulose is a carbohydrate which is acted upon by the intestinal bacteria to produce some sugars or protons which bind with ammonia to form ammonium ions, which is not absorbed into the GIT. So lactulose is one of the treatment. That's why enema is given. But what are the triggers for hepatic encephalopathy? I told only protein degradation leads to ammonia formation. So high protein diet leads to hepatic encephalopathy. Remember, blood is also a protein. So if there is a upper GI bleeding, or if there is a variceal bleeding, that also will trigger hepatic encephalopathy. Then some drugs, electrolyte imbalances, constipation. Because when constipation is there, more of the proteins will be acted upon by the bacteria, leading to more ammonia. Right? So one is the varices, next is the hepatic encephalopathy, next is ascites. Because when portal hypertension occurs, because of this change in pressure, fluid will leak into the abdomen. That is called as ascites. When this ascites becomes infected with bacteria, we call it as spontaneous bacterial peritonitis. Okay. We have some other rare syndromes also, like hepatorenal, hepatopulmonary syndromes. Right. All this occur because of a process called as splanchnic vasodilation. Remember, most of the toxins in the portal circulation are not detoxified. So more of vasodilators like nitric oxide are formed. So this nitric oxide dilates most of the vessels, like splanchnic vasodilation occurs. Pulmonary vasodilation occurs. Because of this pulmonary vasodilation only, we get hepatopulmonary syndrome. When the splanchnic vasodilation occurs, the kidneys will not get much of blood. So that leads to hepatorenal syndrome. There are two types, hepatorenal syndrome type 1 and type 2. Okay. And we discussed sometime earlier that low platelet count is a feature of thrombocytopenia, is a feature of cirrhosis. Right? So the things given on the left side are problems with the portal hypertension, variceal bleeding, hepatic encephalopathy, hepatorenal syndrome, hepatopulmonary syndrome, ascites and SBP. The ones given in the right are the complications of cirrhosis. Cirrhosis as such without portal hypertension. Coagulopathy, because factors 2, 7, 9 and 10 are produced by the liver, they are deficient. There may be bone disease because vitamin D gets 25, one process of vitamin D hydroxylation occurs in the liver, right? There will be hematological abnormalities because many proteins are not produced by the liver. So there will be thrombocytopenia, there will be anemia, etc. So at least remember the pathogenesis of portal hypertension, the types of portal hypertension. So these are some of the symptoms, clinical symptoms of portal hypertension. This is spider nevi. This is Dupuytren's contracture. Dupuytren's contracture usually occurs due to alcoholic liver disease, alcoholic portal hypertension. There may be other symptoms like gynecomastia may be present. Why gynecomastia? Estrogens are not broken down by the liver. So increased estrogens lead to gynecomastia. The same increased estrogen only leads to this palmar erythema or spider nevi. The same increased estrogen only leads to testicular atrophy. The same estrogen only leads to loss of axillary hair. So these are some of the clinical phenomena. So if an image-based or a video-based questions or scenarios are asked, you must pick up portal hypertension. Remember, portal hypertension is different from cirrhosis, right? Okay. So that finishes the cause of cirrhosis. How will you assess cirrhosis, the severity of cirrhosis and portal hypertension. So this completes most of the things in liver, right? So our aim is to introduce the tougher concepts especially scenario based assessment questions, so that you can answer most of the questions in MCQs, right? So hope I did my best. Thank you.